This is a PowerPoint presentation on the assessment of chronic pain patients in primary care. Chronic pain can affect any age group. However, it is very common in the older adult population, affecting quality of life, well-being, general health, physical and psychosocial functioning, and vitality. Undertreatment impairs mobility, decreases socialization opportunities, causes depression, sleep disturbance, appetite loss, constipation, gait impairment, falls, and cognitive impairment. Statistics from the National Institutes of Health show that 25.3 million American adults suffer from pain on a daily basis, and 23.4 million American adults report having a lot of pain. The burden of pain in the United States includes the fact that there are 100 million Americans with chronic pain compared to other major diagnoses such as diabetes with 25.8 million, coronary heart disease with 16.3 million, stroke with 7 million, and cancer with 11.9 million affected. The cost of pain ranges between $560 to $635 billion per year. Costs include the medical and economic cost and disability days and lost wages. Chronic pain is defined as pain that typically lasts greater than 3 months or past the time of normal tissue healing. Objectives for this project are to evaluate current processes, review evidence-based literature for evaluation and treatment of chronic pain, review current assessments available for management of chronic pain, provide information and training on pain assessment tools to primary care providers, enhance primary care evaluation and treatment of primary care patients with chronic pain through the use of valid assessment tools and referral, improve quality of life and health outcomes for patients with chronic pain, improve patient functionality in personal life, social life, and employment. Chronic pain disorders are divided into 3 groups. The first is neuropathic pain, which includes peripheral neuropathies, postherpetic neuralgia, trigeminal neuralgia, central post-stroke pain, spinal cord injury, neuropathic low back pain. Mixed pain includes migraine and chronic daily headache, fibromyalgia, phantom limb pain, complex regional pain syndrome, multiple sclerosis, chronic low back pain, myofascial pain syndrome, and skeletal muscle pain. Nociceptive pain includes mechanical low back pain, rheumatoid arthritis, osteoarthritis, chronic inflammatory conditions, somatoform pain disorders, post-op pain, sickle cell crisis, and sports exercise injuries. A typical plan of care in chronic pain patients includes an extensive review of the patient history and past records, review of diagnostic studies, complete physical examination, the ordering of studies necessary for diagnosis and treatment, consideration for additional assessments to supplement diagnostic and physical findings, and share the findings with the patient and proceed with the treatment plan as discussed. We can now move toward the pain treatment planning process. Common diagnostics for treatment of chronic pain include CT scans, MRIs, X-rays, and some laboratory tests that will help provide information to correctly diagnose and then establish the treatment plan. Initial treatment options for patients with chronic pain should include over-the-counter medications, application of heat or ice, rest, elevation of the body part, herbals such as turmeric, return to normal activities, steroid burst therapy could be used, low-dose opioid such as tramadol for short-term, and topical treatments. Also to consider at this time would be physical therapy, occupational therapy, chiropractic, manipulation, yoga, Pilates, massage therapy, acupuncture, and possible referral for medical marijuana. Secondary treatment options for patients with chronic pain include pain assessments, psychological referral for assessment for underlying condition or secondary gain, referral for evaluations such as physiatry, orthopedist, neurosurgery, neurology, endocrinology, evaluation for functional capacity, and possible referral for pain management assessment. The ideal pain assessment tool will have the following attributes: sensitive and free from bias, immediate information about accuracy and reliability, distinguishes between pain, unpleasantness, and emotion, assesses experimental and clinical pain, absolute rather than relative scales, and estimates confidence of predictions. The verbal rating scale, numerical rating scale, and visual analog scale have been used extensively in the acute and research setting to measure pain. They provide simple, efficient, and minimally intrusive measures of pain intensity. The LEGO Pain Assessment Tool is an adaptation of the visual analog scale, can be used for children or developmentally delayed adults, and it tends to be much more acceptable to children. Since pain is subjective, self-report is considered the gold standard and most accurate measure of pain. The PQRST method of assessing pain is a valuable tool to accurately describe, assess, and document a patient's pain. This method also aids in the selection of appropriate pain medication and evaluating the response to treatment. The Fear Avoidance Belief Questionnaire has proven to be a reliable and valid assessment tool based on patients with chronic low back pain. Recent research has shown that in populations with acute low back pain, spinal injuries, musculoskeletal conditions, and chronic pain, this tool has been effective in identifying risk for long-term disability. The Fear Avoidance Belief Questionnaire consists of 16 items in which a patient rates their agreement with each statement on a 0 to 6 scale, with 0 meaning complete disagreement and 6 complete agreement, with a maximum score possible of 96. A higher score indicates more strongly held fear avoidance beliefs. There are 2 subscales, with the work subscale with 7 questions and a maximum score of 42, and any score over 34 is considered a high scale, and the Fear Avoidance Belief Questionnaire Physical Activity subscale with total points possible 24 and a high score rated as greater than 15. Kinesiophobia is defined as the fear of movement. Kinesiophobia occurs when pain is perceived as threatening. Pain catastrophizing occurs, which may develop pain-related fear and anxiety, in turn leading to avoidance behavior. Avoidance behavior is a state when an individual withdraws from performing activities such as leisure, work, socializing, which are associated with high levels of pain, which may aggravate the painful experience. Kinesiophobia is common with Parkinson's disease, fibromyalgia, spinal stenosis, and low back pain. A total score in this Tampa scale for kinesiophobia is calculated after inversion of the individual scores of items 4, 8, 12, and 16. Scoring ranges 17 to 68, and a score of 37 or higher is significant for avoidance behavior. The Kiel Startback Screening Tool is being used by a range of clinicians such as general practitioners, physical therapists, osteopaths, and pain management practitioners to systematically identify patients at risk of persistent symptoms. There are 9 questions about predictors for persistent disabling back pain, including radiating leg pain, pain elsewhere, disability, fear, anxiety, pessimistic patient expectations, and low mood, and how much the patient is bothered by their pain. A total score of 3 or less results in a low risk. A total score of 4 or more with 3 or less on the psych scoring is a medium risk. A total score of 4 or more with a psych score of 4 or more is high risk. In low-risk treatment, the patient is likely to improve with the goal of providing support toward enabling self-management. Consultation with a clinician is very important, and this would be the provider, physical therapist, or a nurse. Assessments would include medical issues and discussion of patient worries, concerns, and social impact. A brief physical exam helps the patient with confidence toward the provider, and this would also include advisements and addressing specific issues. Encouragement is given toward activity and self-management, avoidance of unhelpful labels and medicalizations. Written and oral information would be given, and the outlook toward treatment goals would be explained. Moderate risk treatment is similar to low risk, including the eliciting of concerns and adequate physical examination. Treatment would be tailored according to the physical findings, meeting the specific needs and patient worries. Physical therapy may be a brief session. However, the physical therapy interventions should be specific, such as manual therapy or specific exercises. General function exercise is indicated when there is no specific relationship between findings on the physical and back pain. Treatment objectives should be specific and have end time points. All specific treatment effects should translate into functional improvement and reduced disability. Some patients will need referral to specialists such as orthopedic, neurosurgery, or pain management. High-risk treatment builds on the low and medium-risk plans with the aim to decrease pain, disability, and improve psychological functions. PT delivers the high-risk therapy. The therapist must have advanced training in mentorship and ongoing professional support to enable them to elicit and address more complex issues in patients who have additional psychosocial barriers to recover. The actual PT process is also important. 6 individual PT sessions, 45 to 60 minutes, should occur over a period of 3 months, combining PT with cognitive behavioral approach. The patient must be enabled to manage ongoing and future episodes of low back pain. Specific focus is on cognitive, emotional, and behavioral responses to pain and impact on function. Potential obstacles to rehab must be identified, and there should be identification of possible targets for intervention. The ABBY pain scale is a measurement of pain in people with dementia who cannot verbalize. The total score would reflect 0 to 2 no pain, 3 to 7 mild pain, 7 to 13 moderate pain, and over 14 severe pain. This can be used very easily by primary care providers. The conditions supporting referral of chronic pain patients include the current CDC guidelines limiting opioid prescribing, concern for diversion of pain medication, failure to respond to treatment, non-compliance with treatment plan, history of substance or alcohol abuse, pain out of proportion for the type of injury, or diagnostic findings. Patient expected outcomes include adequate pain control, improved function, improved quality of life, improved patient outcomes, maximized potential for return to personal, social, and employment activities.